Silverman here. I've got my esteemed colleague, good friend, Dr. Jake Cook. Jake, how are you today?
Very well, thank you, Rob. Thanks for speaking with me.
I'm happy you're here. Actually, he's right there. So I'm waving. So everybody knows I'm at the ECU. Yesterday I had Dr. Eric Reese. Today I have Dr. Jake Cook. So we have a very interesting setup in that we're sitting right next to each other. We're sharing one mic, but we're ready to go. We have a great podcast coming. We want to talk about low-level laser and the impact that they make. And remember, lasers are used as a leading modality in America and in Europe. And what's fascinating about lasers is that the ones that we recommend have no heat. And what's drawn us into using laser has been our life's experiences. So I had told everybody yesterday, I bought the laser first 12 years ago for myself to help with my torticollis. And Jake has a very similar personal story.
Yeah, so my wife was pregnant with our first child. She was in the third trimester. She had about 10 days to go before her due date. And unfortunately got sinusitis. And when you're that pregnant, there's nothing you can do. So you can't take any antibiotics. She was advised not to take any painkillers. Our GP was very helpful, but basically said, unfortunately, you're just gonna have to put up with it and get on with it. So I came down one morning. She's a real trooper. My wife, she's really tough. We come down and she's just head in her hands on the sofa, not talking. She's like, it's 10 out of 10. I just need to kind of cope with this. So in theory, we're not really meant to use laser with pregnant women, but I was like, this is insane. She's, this can't be good for her or her situation. So we took that laser with the blue red light and we just shone it around the sinuses for basically like 5 minutes. So not doing anything else, just doing laser. My wife is a skeptical person, so there's no hocus pocus going on. And at the end of 5 minutes, she basically just opens her eyes up. And she's like, oh God, my headache's gone. And she's talking full headache, not just sinus pain, full headache. And at the end of 5 minutes, she opens her eyes up and goes, God, that headache's gone. I can still feel like a throbbing pain here, but like I can open my eyes, like this is amazing. So we repeated it again later in the day, did that more for like 2 more days, and it just gone. So for me, I'm now not telling every single patient advertising I can treat sinusitis all over the place, but for me, that was my first real experience of like, oh, that wasn't a subtle change of, oh, we need to do this 5 times a week for the next 3 weeks to see a little bit of difference. That was wow, that's an instantaneous change. And I don't have any other tools in my workshop that I think could have done that. It doesn't matter how much soft tissue work I did or fascial release or whatever, I'm positive that outcome wouldn't have happened. So that was kind of my first moment where I thought, wow, this is significant. And I've suddenly felt a lot more confident using it and recommending it to patients.
It's funny, again, like to reiterate, when you have it, something that's personal. So we as chiropractors, again, I think I've said this before in the podcast, we're driven into the field because somebody affected us in such a positive light, change our matrix, change our life. And the same thing holds true when you look at modalities and techniques. So again, when you see that really changes your outlook. That changes your trajectory on your career. That said, you and I both use the lasers for a multitude of conditions. So I know you're more, again, functional neurology based, and you do a lot of radiculopathy, more musculoskeletal, functional medicine. So let's ask you a little bit about some of your functional neurology and cervical radiculopathy cases.
Mm-hmm. Yeah. It's easy to use. Sometimes I think it's a bit stupid proof, really. We often talk about like, well, how do we do hands-on treatment? And I sometimes think, well, what's the point? It's just shine the light on it. Where does it hurt? Shine the light on there. Shine the light on the spine, and then get on with it. Really, it's the simplest thing. By the way, I love what you and Simon were talking about, like changing the settings to like acute, subacute, chronic. That's a much simpler way to think about it, rather than nerve root, muscle, all that other complicated stuff. So people are always worrying about what frequency we do use. I think much better idea is just think, what do we use for the acute setting, subacute? Anyway, but for radiculopathies, particularly, I see more lumbar radiculopathies than I do cervical. I just do everything I would normally do. We're all chiropractors or manual therapists. You already have your own skill set. So I just do exactly what you normally do. And then at the end of it, I'll just use the laser over the nerve root at the disc level where I think it is. And we'll start off with them passive, just lying there. Because they're in pain, I'm not going to have them do lots of active movements like I might with a shoulder. And I'll literally just have them tense their stomach, because you can't say to someone, tense your back. They won't know how that is. So tense your stomach, hold for a second or two and relax. So we'll do that kind of active contraction. And I got this from you, Rob. My big takeaway for it with showing patients the value it has is you've done all your other stuff and you poke it and you say, how sensitive is that? And with a radiculopathy, it's still going to be sensitive. So they're still like, it's like a 6 or 7. Cool. Poke, poke, poke. Laser, couple of minutes, straight away, poke, poke, poke. How painful is that? And I say normally they're going to reduce it by about half. So if they said it's about, an 8, they're going to say it's a 4. If it's a 6, they're going to say it's a 3. And that for the patient is great value. They suddenly see what that laser did rather than just trying to explain to them the biological benefits of the laser. It's nice to show them you want pain relief. You didn't come in for biological optimization. You came in for pain relief, and there it is. Especially when you've already done all your clever hocus pocus stuff and it hasn't quite maybe had that miraculous effect you're hoping for. And then you can be like, and there it is. Walk out the door, go tell your friends, I'm the guy.
No doubt about it. It's a game changer for anybody in practice. Anybody who wants to try it should really seek out someone that has an zirconia laser. That said, I got a lot of good stuff to unpack there. Number one, radiculopathy. We're talking about a peripheral nerve. We've got our central nervous system, our spinal cord and our brain. And then we've got these peripheral nerves. 635 nanometer light was shown to be quite effective by Rockkind. He showed he was able to increase action potentials. So the ability to have an action potential will, I'll say, volumize and modernize the nerve. You talked about the 3 phases of care. I really want to delve into that a little bit. So as a lead clinical consultant for Aconia in Europe, we've now done these 3 phases. Phase 1 is acute, where inflammation is a major problem. Some of them, and you know this, in a musculoskeletal light, especially in America more so than in the UK, our patient population is not that healthy. 75% of Americans are overweight or obese, 12% are metabolically active. So they start pre-inflamed. Then they get an injury and they're too inflamed. So that acute phase puts them literally on fire. So acute happens in the first 3 or 4 days, where you really want to deal with inflammation and cellular debris. Phase 2 is the subacute, day 4 through week 8. And in that period, you get a repair and a remodeling of soft tissue. And then hopefully we get to performance and wellness. The biggest problem you and I suffer from is the patients come in a chronic condition. So we break it up into 3 phases of care to keep it a little bit more simplistic. But at the very end, we have to engram what they learned. And that's called proprioception. So I'm going to throw the softball for proprioception and cerebellar function and put it right back on you.
So cerebellum really is all about, it does everything, right? It just coordinates everything. But traditionally we're going to say it coordinates movement. We know more than that now. We know it coordinates your autonomics. We know it coordinates emotion, memory, learning, everything. But really in a chiropractic paradigm, we're interested in its ability to coordinate movement. Everything you do as a chiropractor is going to activate cerebellum, whether you want to or not. So even if you only do manipulation, fantastic, great news, that's activating the cerebellum. If you do lots of soft tissue work or you're very rehab based, fantastic. Doesn't matter if you're really focusing on improving stability of the shoulder through scapular setting exercises, great news. The cerebellum is the one that's coordinating that movement for you. So what we're going to do at the end of treatment. So I actually have quite long treatments with patients. I have half an hour. So I'm doing a passive treatment and then finishing with active. So we'll do some rehab exercises. And then when they're doing those rehab exercises, what I'll often do is, let's say they're doing a balance exercise. I see a lot of dizziness, chronic pain. You're going to see the parts of your brain that can control the spine, that control curvature of the spine, stability, things like that. Basically, the parts of your brain that control movement, balance, posture are right in the middle. And so what we're going to do is, while they're doing like a balance pose, because people are always going to benefit from doing balance exercises, we'll basically stand behind them. And then we're going to use the laser over the cerebellum. So we want to try and, while the cerebellum is busy coordinating movement, balance, posture, we want to give it some energy to say, because the laser effectively is, we can talk about you, particularly Rob, can talk about all the clever stuff it does. One of them is we think it helps with kind of cellular communication. I was looking at an interesting study recently where they have rheumatoid arthritis, and so patients have, unfortunately bad Clory type hands. They were lasering this hand, but testing the pain on the other, which is quite cool. So laser this hand and then see what the pain sensitivity is on the other. And the pain sensitivity was reducing. And that is quite a cool study because it suggests that you're not just getting a local mechanism action, you're getting a more central thing. So something is helping the nervous system control pain in a better way or reduce inflammation in a better way.
Well, you get the crossover. I know you can talk about that. You get that 10% crossover from one side to the other.
Which is pretty cool.
Yeah, that's really cool. I'm sure everybody on this early Sunday morning back in the USA is like, wow, I didn't realize that one side of my body can affect the other, but the body's all interconnected, both up and down, in slings and across. That's the whole premise of the blood system, the bloodstream, if you will, the neurological system, the muscular system, fascia, and the like.
So to bring it back to, the original subject was radiculopathies. Obviously, when we're going to have a lumbar radiculopathy, it suggests that the ability of the body to control mobility and stability has probably been compromised at some point. So if we have a joint, try and get my arm on this small screen. Mm-hmm. If a joint is very stiff and stable, it's very safe. So if I fuse my elbow, there we go. If I fuse my huge bicep so it can't move, you can run against this. It's not going to dislocate. It's a nice, stable, stiff joint, but it's completely unfunctional, right? I can't use it for anything. I can't shake Rob's hand. I can't use it to use a pen. I can't open a door. So we're going to sacrifice some of that safety and that stability by offering more flexibility. More flexibility gives me a better range of motion, more function, but a higher risk of injury. So our brain is trying to constantly balance this stability versus flexibility. It's complicated. That's why we have this huge, to stand upright, we had to develop whole new areas of the brain that our primate cousins don't have. So we developed these new areas of the brain to control this upright posture. We want to make sure that the areas that are central in kind of the brain stem and the brain, so thinking vestibular nuclei, cerebellum, stuff like that, are working really well. So we want to do our local treatments, and then we also want to think above that. You got spinal cord, you got brainstem, cerebellum, cortex, and we want to go up. So that's why I'll often finish with, I've done all my kind of pain stuff to do what's important, to be honest, what the patient wants is the pain relief, and then to try and help them stabilize at home and improve that by making sure that cerebellum and descending vestibular spinal tracts are helping stabilize the spine as well as possible.
You said in a very articulate manner what Thomas Edison was trying to say, in that the body's sole purpose is to carry and support the brain. Mm-hmm. So the brain actually enables us to have stability, which you essentially said was first. I agree with you. We want stability in joints. We want stability in muscles. We want stability in structure. Then to have mobility. And then lastly, flexibility. Mm-hmm. Too much we've seen people go for the flexibility first. Mm-hmm. Is the hamstring tight? When it's not. It's not that the hamstring's tight. It could be the psoas is tight. It could be a neurological intervention that's aberrant. Mm-hmm. So I think that's a great encapsulation. So everybody, the brain is the save button. Mm-hmm. It's your hard drive. Everything outside is your soft drive. That said, you do more lumbar radiculopathy. What's the number one thing you see in the upper quadrant?
Obviously, neck pain is obviously a big one. Shoulder pain is a big one. In terms of nerves, it actually tends to be that neurogenic TOS, like thoracic outlet syndrome, which is an interesting one because doctors only often think that there's it has to be like a cervical rib that's you've got a real structural thing. So it's really interesting because chiropractors and physios are seeing TOS all the time, where we've got these hypertrophic scalings. We live in a really stressed society. 2 years of COVID, everyone's stressed. Yeah. People who didn't used to suffer from anxiety now do. So we developed this apical, this stress breathing pattern. These scalings hypertrophy, they get too big. We're at a computer all day, typing away. So we're compressing that brachial plexus, and often we're going to hit the lower brachial plexus. We're going to hit C8, T1. So we're going to get that pain to the anterior chest, maybe down to the medial aspect of the arm, all the way tingling into here. So that's a big one I see. Often, sometimes we can have a variant of TOS, which would be Pec Minor Syndrome. So as that nerve bundle comes up underneath the clavicle, it's going to go under Pec Minor. And when Pec Minor basically rolls my shoulders forward. So if I'm behind a computer all day and I'm stressed about it, we start to compress the brachial plexus there. Classically, you're going to get that pain at the front of the chest, comes up under the armpit or down to the arm. I find personally that if I'm using the laser, it's normally for pain or it's for peripheral nerve. And so we're going to, again, just use laser right over that brachial plexus. I do all my soft tissue work first, right? I want to stretch those scalenes. I want to open up that brachial plexus, because in my mind, there's no point using the laser first and then just walking away if they've still got all this aberrant movement pattern. So we're going to stretch everything out, do some scapular stabilizers, do some belly breathing to try and disengage this. And then we're going to use the laser to really reduce inflammation, because if we still got that inflammatory process going. Have you ever seen people who have puffy bits here. Have you seen that, Rob?
Absolutely.
It's literally like puffiness. And for me, I just think that must just be like venous, like you're not draining all that lymph very well. You literally get this like soft. But I used to refer people out for X-rays all the time, like where they've got like a tumor or something. And it's not, well, it might be, you need to do your homework on that one, but it's just they're just super tense, they're super tight, and they're not draining lymphatic fluid, and literally this puffy stuff, and it goes. And I think for me that the laser is really good at kind of restoring that neural function. And that's a great one for your pain testing, right? Who isn't sore here? Like I'm sure even, hopefully you, me and Rob are the healthy ones. And I'm sure if I dig around a little bit, I'm going to find something sensitive.
Absolutely.
So it's great to be able to laser that. And then literally, I just had this with a professional rugby player here in the well, we're not in the UK. I live in the UK. In the UK, rugby is one of the big sports. We've got a big professional team just down the road. This guy had a compressive, he's in the scrum, which is where you get these crazy guys who just interlock heads and then just push as hard as they can. So you got the biggest, strongest guys on the pitch, literally just ramming their shoulders and heads together. And he had a bad compressive joint injury from just like, not like a whiplash where we sprain the facet, the exact opposite, where we're just really crushing it. We think there's two ways to really injure joints. One is compression and the other one is distraction, right? Or shear force. So he's had the office really bad compression, but his main complaint was he was saying he was getting this terrible shooting pain from here coming up into the back of his head. You poke around in the brachial plexus and he's like, this guy's tough. And he's like, that is the worst thing anyone's ever done. Please don't do that again. The first treatment, did my manipulations, did some very gentle like work over the scalenes. And he's still like, please don't touch it. Laser. We did about 5 minutes because it was so tender. 5 minutes later, you're like, how's that? It's like, wait, there's that lovely light bulb moment where they're like, what? Is that normal? I'm like, yeah. He's like, oh, that's cool. So now he's gone back to his physio who's been struggling to manage that condition, and everyone's happy. The key is you still need to do rehab, right? You still had a compressive neck injury, so it's not like I've just lasered it and it's all fixed. There's still, he's got aberrant movement patterns from years of compressing, so there's still stuff to do, but it's quite exciting to be able to, in a very short period of time, switch that off.
That's a great story. And again, like you said, rugby's big in the UK. In America, we use American football. A lot of connections, a lot of collisions, concussions, really popular. But talking about the scalenes, here's your scalenes and what goes through them. Your scalenes anticus and medius, your anterior and medial, is the brachial plexus. So when those scalenes get tight, it grabs the brachial plexus. Wow. Early in the morning for me, everybody. If I
day 3 of a conference.
Day 3 of a conference, like 4 o'clock in the morning for me. Interesting that it grabs it, and that's why you get that congestion. So I agree with you. I think that a lot of doctors think it's a cervical rib, and when the data is, when you do a literature search, there's not that many cervical ribs. It's not that prominent. It's more this anterior head posture. We live in an anterior head posture world, and again, you were using the laser amongst other treatment protocols. Soft tissue, chiropractic manipulation, some assessment, some neurodynamic tests to really position the laser. People ask why and what is non-thermal low-level laser. Well, it is a treatment standalone that has an FDA clearance, but it's also synergistic with any kind of treatment that an osteopath, chiropractor, or physical therapist would treat. So let me ask you, we're getting close. We're going to have a short one today. We're going to let everybody get to their early morning breakfast. Where do you work? How can they get in touch with you?
So I'm in Woking in England. So people hopefully know where London is. It's kind of like in the southeast of England, and I'm at 9 o'clock. So if we put a clock face around that, I'd be at 9 o'clock just outside the M25. So I've been in practice there. We've opened our clinic about 4 years ago now. So, but I work mainly with chronic pain, chronic dizziness, and lucky enough to teach people around those kind of subjects. And that's how I get to meet you, Rob, and spend time in this lovely foreign city having a chat and a couple of, not drinks. You don't drink at all. You're very well behaved. Yeah,
I'm well behaved. I'm an American gentleman. Just a little good organic coffee. That would be great. So nobody better than Jay Cook. We got a little laughter. A couple of people watching us. Nobody better than Jay Cook at Functional Neurology from London, talking about a corneal laser. And you guys have any questions, feel free to reach out. Everybody have a great Sunday morning. Thanks a lot, Dr. Cook.
Great. Thanks for having me.